ASCP is really there to help provide you with the education and resources necessary to make sure that you can take care of the older adults in society. So on the right of this slide, I've included the pictures of our two faculty advisors, Dr. Gervich and Dr. Taban. For those of you who were at our presentation last year, you'll remember that Dr. Taban presented about his background and what got him interested in geriatric pharmacy. They both see patients at their respective clinics and their faculty at the School of Pharmacy, and they've helped get our chapter off the ground. So our chapter is fairly new. It was our first active year this past year before it got cut short. And Marcella will be telling you guys a little bit about the events that we've had and upcoming events that we'll be having in the future.
All right. Hi, guys. Again, thanks for being here. And also, again, I'm the incoming Director of Membership and Recruitment. So we just wanted to go over some events we had just to kind of reflect on who we are outside of pharmacy and the combination of pharmacy. We unfortunately don't have an updated list of what we have upcoming. So we do have a tiny URL for you guys to sign up with, so that way you guys can be on our listserv to find out about events that we're having, volunteer opportunities, just a kind of a way to stay connected, even as at an undergraduate level. Definitely sign up to be active with us. It'll be great to have you. But I did want to focus on the ones that have the asterisks next to them. And we wanted to focus on those because those are kind of the ones that you guys would be able to volunteer with and get some good experience with the members, faculty advisors, and geriatric pharmacy in general. So the Walk to End Alzheimer's event, we raised money. It'll be the top two pictures. We raised money. I just asked members to, post on Facebook, try and raise any funds that they could for our chapter's walking group. And so that's some pictures of all of us at the actual walk, which was at the LA Zoo. The next event we want to talk about was the Brown Bag event. Unfortunately, due to COVID-19, that had to be canceled, but we wanted, when we were talking about how we wanted you guys to be involved, it was more for you guys to have a good, it would be a good opportunity for you guys to shadow, kind of see what we do on the pharmacy side at a Brown Bag event. I won't go into the specific details, but that's another great volunteering opportunity. And then lastly, the holiday party. We hosted it, our faculty advisor, Dr. Gervich, she hosted it at her house. And it's just a good way for everyone to kind of release from pharmacy and everything else and just kind of bond. We get to know the faculty advisors on a personal level. So it's just a good, casual, fun event. And one other thing I wanted to mention were the workshops and the panels. So for the panel, we got to have some undergraduate students. It was a nighttime event, so we were able to have some people come out from other campuses and sit in on this panel, which was a really awesome event. We got a lot of good feedback about what everybody learned, and just some good insight as to what a geriatric pharmacist does. And then also for the clinical case workshops, it's during our lunch hour, but we're going to try and see what we can do this year about getting them recorded so that you guys, if you guys are interested in learning about them, we can get those sent out to you. But I want to really focus in on the presentation that's going on today. So we'll hopefully be around for Q&A, or email us if you have any more questions.
Great. And I know this is a lot of events to throw at you guys all at once, but if you guys want to find out more about any specific event, feel free to email us. Just a really great opportunity for you to see how to approach patient cases as senior care pharmacists do. So with that being said, we're going to go ahead and just jump into Dr. D's presentation, and we'll have Karolina here to introduce Dr. D.
Okay, hi everybody. Can you hear me? Okay, great. So our guest speaker today, we're really privileged to have Dr. Demetra Antimisiaris. She is a certified geriatric pharmacist that will be speaking to us about polypharmacy, which is her specialty. She's also known as Dr. D. So Dr. D earned her Doctor of Pharmacy degree at the University of the Pacific, and she completed her geriatric clinical pharmacy residency at the VA Medical Center in Los Angeles. She is a certified geriatric pharmacist and fellow of the American Society of Consultant Pharmacists, and she joined the University of Louisville Family Medicine and Geriatrics faculty to lead the Polypharmacy Initiative. And so this project is now known as the Jean Frazier Polypharmacy and Medication Management Program. And it's a really unique program that is dedicated exclusively to fighting the problem of polypharmacy through education, research, and outreach. And if you would like to learn more, you can click on the here in red later on once the presentation is sent out to you guys. But without further ado, please give a warm welcome to Dr. D, and we're really excited to hear her presentation.
Thank you so much, Karolina, and thank you everybody for having me. It's such an honor, and it feels a little almost emotional because I'm from Southern California and I live in Kentucky. But I'm just really excited to talk to you guys about geriatric pharmacy and kind of my career path, in the hopes that it helps inspire you that there's a lot of things you can do with this profession. Do I have share screen now? Should I go ahead and do that? Okay. Let's see. I think I've got the right one. Is it working?
Yes, we can see the screen.
Okay, fabulous. All right, thanks. Well, as Karolina mentioned, I'm a longtime member of ASCP and actually have just become the associate editor of the journal. So kind of branching out into the scholarship and helping to create the publications that are of value to the membership. We find that there's a real gap in understanding geriatric pharmacotherapy by the pharmacist at large, and at the same time the pharmacist at large is taking care of a lot of older people. As you know, the aging of the boomers is causing the percent of older people to almost double within the past 20 years. Let's see, am I able to move it? Yes, okay. So I just wanted to briefly explain how my career got me to this point. This is a picture of me when I was in seventh grade. And I was raised by my grandparents. And a lot of people who go into geriatric care, whether it be medicine, geriatric medicine, or gerontology or geriatric pharmacy, a lot of times it's because they have some kind of tie to older adults in their life, in their family, or in other ways. My family is, in full disclosure, a fourth generation USC family. And because I did my residency at UCLA, I got treated pretty badly by my family. But then they forgave me after the fact. Any of the VA systems have really good geriatric pharmacy programs, and geriatric pharmacy residency is a second year residency. So first you do a general residency, and then the second year you can do geriatrics. After that, you're really well qualified to be a consultant pharmacist. And as mentioned before, a consultant pharmacist is somebody who consults the nursing homes, because by law, every month, those charts have to be reviewed by a pharmacist. But also the assisted living facilities are increasingly being regulated, and some of those are really pretty nice places. They're some of the very fancy retirement homes that you see around, and consultant pharmacists also work for those communities. Some of those jobs are private contracting jobs, which is kind of a nice thing. You're not really working for a big corporation, and they really value your input, because as you could imagine, and based on maybe your work in a pharmacy or just people that you know, older people have questions about their medicines like almost literally every day. So I have friends, I have a lot of friends in Hawaii. I grew up half in Hawaii, and I lived there most recently before here. And they do a lot of private contracting to assisted living facilities. Also, the dialysis, the places that do dialysis, they use a lot of geriatric pharmacists as well, because they have huge lists of medications and complex patients. And those are the skills of a geriatric pharmacist. A geriatric pharmacist is able to deal with a lot of complexity at the same time. And I'll explain later how that ended up qualifying me to lead the career that I do now, which isn't exclusively geriatrics, but those skills earned there at UCLA and West LA in geriatrics really got me ready for doing what I do now. So after I was recruited from Hawaii to come and work at University of Louisville, and you wonder, well, why would they bring somebody all the way from Hawaii over there? And they interviewed about 15 people to try to fill the position to lead this polypharmacy program. And I guarantee you, it's not that I'm really smart or anything, but it turns out that on paper, my application had checked all the boxes that they were looking for. They were looking for somebody who was trained in geriatrics at a certain place. So back in those days, only like Duke, UCLA, Stanford, Chicago, Boston or UMass, and Florida had these Reynolds Foundation training centers. And so because of that, they offered me this job. And this job is basically to lead a program to study polypharmacy. So that doesn't really imply just older adults. But the only people who kind of understood polypharmacy about 20 years ago were the geriatric pharmacists. And today, polypharmacy has become ubiquitous. Even middle-aged adults suffer and live with polypharmacy, and children too. Part of my job also is to teach basic science learners. So I teach in the medical school, basic pharmacology. I also teach the clinical learners. And so because this career has given me the chance to work in a lot of different venues, my research is really around decision-making and medication use. What I learned was that all these different stakeholders, the consumer, the nurses taking care of the people in long-term care, the medical students, when they become physicians, when they're postgraduate learners, everybody has a different view of the exact same medicine. I don't know if you've ever noticed that. And the more you get to know about medicines, if you ask 10 different people about, ibuprofen or Motrin, you're probably going to get 10 different answers. From an older person, you might get, that helps my arthritis. From a cardiologist, you might get, don't take that, it'll raise your blood pressure. So what I'm interested in is kind of why people make the decisions they make about medication use and the hidden impact of polypharmacy. So just to mention that one of the reasons why being a consultant pharmacist is like the perfect fit and a really good job for a geriatric pharmacist is because there was something called OBRA 87. And that means in 1987, the federal legislature said that a pharmacist must review every chart in a nursing home once a month. And it turned out that they used to just hire any pharmacist to do it because obviously they didn't have specialized trained pharmacists. Today, if you almost have to have a board certified credential to do that job. So this is kind of tip number one about your pharmacy education. Whether it be geriatrics or whatever you do, you should always target getting credentialed in or board certified in your area of interest, because pretty soon we're going to get reimbursed based on our jobs. So I can foresee a future where the consultant pharmacists, when they go to do a chart review, they'll get paid for it by Medicare. Right now they don't. The nursing home pays the pharmacist. because they need the pharmacist to get the quality outcomes so that they don't get fines. But in the future, we're going to be able to bill for our services, and you won't be eligible to bill unless you're boarded in that area. So for example, an analogy would be like if you're a neurologist and you do a EEG to check if somebody has seizures, you can't bill for it if you're not a qualified board certified epileptologist. You know, if you're a family medicine doctor and you do an EEG, you really can't bill for it. So keep in mind that you want to think about directing your training towards your area of interest. You don't have to decide right now. You know, most people decide later when they're interns or fourth years. But then you want to work towards getting a board certification. And when it comes to senior care pharmacy, there's a big shift in the way we approach the patient. The traditional approach to a patient would be somebody sees a patient for a problem. So a cardiologist sees a patient for a heart rhythm problem. And their job is to fix that problem with pretty much disregard to all the other problems that are going on. And that works okay in younger people, but in older people, it doesn't work very, very well. And so this is an area of interest of a person named Cynthia Boyd, who is at Johns Hopkins. And she's trying to reframe the way we do clinical studies to include a multifactorial approach to problems. So, you know, older adults, they have like COPD, so disease number 1, heart failure, disease number 2, and that causes syndromes. The combination of physical debility and multiple problems like diagnosis leads to syndromes. And some geriatric syndromes include dizziness, confusion, urinary incontinence, falls, and cognitive impairment. Those are all things that are not real organic diseases, but what they are problems that are common to people who are older. And those problems develop because of all the underlying diseases. So the point is that in geriatrics, the ability to get evidence-based medicine and clinical trials on and get good evidence on older people depends on our ability to study the problem in light of all the other syndromes the person's dealing with, instead of just focusing in on one problem at a time. You might know that if you have diabetes and you're older, you don't want to aggressively control your glucose level because it turns out it causes higher mortality or death rate or harm than if you kind of loosen up the targets and you try to let the glucose levels be a little higher, because the effects of low glucose are pretty damaging to an older person who has a lot of syndromes and debility. One of the problems is if you keep your glucose too low, you can kill some brain cells. And so you get more cognitive impairment and dementia. So that's kind of an illustration of why we need to study problems in older adults differently. We can't just study them as if it were for a younger person. So here's a picture from my old job. This is a nursing home in Hawaii. And okay, it's kind of a joke. I locked down this guy's fan because he kept putting his fan on everybody. And so I put a lock on it. He's not happy. Anyways, this is the greatest place in the world to learn about geriatric pharmacy. Just working with the people who do the day-to-day care of older adults is like 90% of geriatric pharmacy, understanding what it takes to help an older adult who's very frail, you know, have a quality of life. That's really the focus. And all of the geriatric pharmacotherapy kind of follows that, because when it comes to pharmacotherapy in older people, the goal is not necessarily to contain a chronic disease. Like, again, with diabetes, you have to contain diabetes for 10 years to get any benefit for the kidneys or the eyes. And if the person's 90 years old and they can, you know, barely walk, what's the point? You know, so you want to think about their quality of life and how much medication and therapy do you want to inflict on somebody when you consider the benefit. Also, a consultant pharmacist, in addition to going through the geriatric pharmacotherapy, the charts, also helps the nursing home or the assisted living facility adhere to regulations. You might not know this, but assisted living facilities are the highest regulated industry in the world. You think about like airplanes and aerospace, that they're more regulated than any other industry. Nursing homes have more regulations. It's really extreme. So part of the consultant pharmacist's job is to go through the medications on site, make sure that none are outdated, make sure that they're labeled correctly. For example, if you open up an insulin pen, it may be only good for 48 days, but if you didn't put the date when you opened it, well, then how would you know when it expires? That's another one of the things that consultant pharmacists help with. We also help with operations. We represent, unless you're an independent contractor, you tend to represent the pharmacy that serves the nursing home. This is the crew. This is the director of nursing, the administrator, and two of the nurses at a nursing home in Lanai. Lanai is across from Maui. It's like a little 8-bed critical access hospital, but it has no doctor. So I would go there every month and check on the 8 patients that they had. And really that nurse, the head nurse, she was both, the doctor, the nurse, the everything. And when I'd go there every month, I really felt like my help made a difference. And the more rural your work is, oftentimes the more they rely upon the pharmacist. But I would say in general, in nursing homes, they're just so happy to see a knowledgeable person walk in the door. It's very humbling, and it's a great experience. The other thing I would mention is that geriatric pharmacy is an interdisciplinary sport. I'm sure that you've figured that out already in talking to the USC ASCP group, that they do a lot of work with the physicians and nurses and social workers. And it's very interdisciplinary. When you see a patient with a big group, not just pharmacists or not just doctors. It's kind of cool. And this career has surprisingly brought me through a lot of different places and to collaborate with a lot of different people, including to this day, even though I graduated residency there, I'm on the committee for this UCLA Geriatric Medicine Board Review, and it is interdisciplinary, and it's a lot of fun. We do that every year. And I've got to author some books, and I think that there aren't a lot of careers in pharmacy where you get that chance to collaborate interdisciplinary like you would in geriatrics. Now, you all are aware that the boomers are aging, and I'm going to pick on myself because I'm a boomer. And the boomers are a different cohort, and they're going to be your problem. Sorry. They are people who lived pretty hard, a lot of alcohol, a lot of drugs. And the truth is that the boomers are 50% at risk for substance use disorder, whereas the World War II generation and the Korean War generation were only 9% at risk. So there's a lot of open areas of discovery and of research when it comes to the aging boomer. So that's another reason why going into geriatrics will assure you a career. First of all, there's a ton of boomers. The amount of boomers is doubling. I think from 2010 till 2030, the number of boomers is going to double. And the population pyramid is upside down. So there's not enough young people to take care of all the old aging population. So if your expertise is in geriatrics, you will always have a job. Okay, you guys know lots about the American Society of Consultant Pharmacists. I didn't expect that wonderful intro and discussion about the club, so I'm going to skip this part. This is just to remind you that ASCP gives free memberships to students, and that their web page has a lot of resources. This is my group at the University of Louisville. We have, these are all physicians, these are nurse practitioners, and then me. So it's truly an interdisciplinary group. It's really nice. Here's another thing that I do, and I think that most pharmacists do, which is public service announcements and stuff.
Our
So
next guest is on a crusade.
I don't know if you can hear that.
We are taking too many pills. Get this, the typical Kentuckian fills about 17 different prescriptions a year.
Wow, that's compared to a U.S. average of 12. So what's going on? What are the dangers? Our next guest will be speaking about this tonight as part of the Boom Time series at the Public Library.
Say hello to Dr. Demetra Antimisiaris. I got it. All right, our Dr. D, as we like to call
Hi,
it.
Dr. D.
He would say, you're not going to say it right. U of L School of Medicine. This is amazing, 17 prescriptions. And we were saying, so does that mean overuse, a red flag for abuse? What do you call it?
Absolutely. We are undergoing kind of a silent epidemic. The multiple medication use that we're seeing today is unprecedented. And when you see people using upwards of 17 medications together, the red flag is that, think about it, how hard is it just to even take an antibiotic for 2 weeks straight? Imagine trying to manage 17 medications.
Crazy.
How much of it is pressure, do you think, just cultural pressure, where we always see ads for, they have this little thing, here, we can fix it with this?
Yeah, absolutely. The reason this is happening are several. One is extreme marketing towards the consumer, that there's a pill to fix every problem, even problems that we didn't know we had, but the pharmaceutical companies are telling us that we have. And so we go to the doctor looking for prescriptions. That's problem number one. Problem number two is the healthcare system's only allowing the physician 15 minutes to see you and address your problems.
Oh, wow.
And studies show that that breaks down to really 7 minutes. So if you're taking 17 drugs, do the math.
You are not going to get, and you said the paradigm has shifted, which I thought was interesting. It used to be you had one doctor.
Yeah.
They knew everything about you. Now it's multiple doctors, different people prescribing it. Who's in charge of you?
Exactly. And so the whole kind of point of our mission, and we appreciate your helping to raise awareness, is that the consumer, the patient, has to advocate for themselves. Until the system evolves to a better way, it's up to us to defend ourselves.
It's tough for elderly.
Very
I mean, that's
Indeed.
what we were.
But yeah, our own moms and dads, we've talked about too, and the difficulties as your parent continues moving into the latter stages of their life, they're not as sharp as they were and may not perceive that they're under siege.
Yeah, and that's one of the huge problems with polypharmacy or multiple medication use, is that it's hard to determine whether a drug side effect is actually a disease or a drug side effect. I mean, the ability to know whether you took something, one of the 17 things that you took, whether it's causing you not to sleep or not, it's kind of hard to sort that out. So imagine if you're old. I mean, there's just no way that you can really defend yourself. And so what we're trying to do is get people to be more aware and read up more, learn more, and look hard at what they're taking.
We have about 30 seconds left. Who should come tonight?
Anybody who's got a loved one or who themselves is are taking multiple medications, even if you're taking 5 medications and you want to learn how to be aware of this problem and how to fight this problem, my goal is to give you the tools to increase your ability to defend yourself from medication harm.
Which is the awareness in and of itself.
Yes.
Thank you, Dr. D.
You're
Really
very welcome.
appreciate
Hey,
it.
Dr. D, you're married to a doctor. Who's the smarter doctor in the house?
Obviously me.
There you go.
Dr. D will be speaking tonight at the main library. Her husband will not be in attendance after that. Starts at 6 o'clock. Our next guest is on it.
All right. So point is that, a lot of what pharmacists do is education and more education and more education. And I'm probably pretty sure you guys realize this because you're young people, but there are so many opportunities to provide value, to make a living, providing education to non-healthcare people. I mean, the need is tremendous. So I want you to keep that in mind. And this problem of polypharmacy, if you get really good at medication management, those skills are in demand everywhere. Physicians aren't that great at it because, again, they're very specialized. And so you can easily have a consulting business on your own. And I wanted to point out that polypharmacy is no longer just a problem of older adults. It's becoming quite a problem in middle-aged adults and even children. So now we're starting to study polypharmacy in younger people, and we're finding that medication harm does occur when you hit about 10 medications taken at the same time for middle-aged people. So in older adults, it's 5 medications taken at the same time. But the trick is to get people to use their medications appropriately. So medications aren't really harmful, just because they're there. They're harmful because they're not used with close monitoring, or they're prescribed at the wrong dose. And so that's our role as the clinical pharmacist. I want to close with a case that I think you'll find very interesting. Remember, we were saying how the aging boomers are a little bit different. And this lady is an aging boomer, one of the older boomers, and she came to our clinic with hip pain. And she'd been coming to our clinic probably about 3 months and complaining about hip pain. She didn't have a lot of other problems. She was pleasantly demented, meaning she was pretty functional. She lived in the community. She lived with her husband. She could take care of herself. She had some rhinitis. She had some arthritis. She had a little bit of high cholesterol, a little bit of hypertension, and an occasional lightheadedness. She had a history of colon cancer in 1980. She had depression, sciatica, and intervertebral disc degeneration. Her past surgical history was remarkable for what's called a Roux-en-Y gastric bypass. And so what was popular in the 1980s was to do a gastric bypass where they just reduce your stomach permanently down to about a 30 milliliter pouch. That's it. Today they do like a gastric sleeve procedure, and it's not nearly as damaging. The Roux-en-Y procedure makes it so that you can't absorb food very well, you can't absorb nutrients, and a lot of those folks, interestingly, she's got dementia. She may not have had dementia if she didn't have a gastric bypass, because on the neurology side, I'm actually appointed in neurology too. We see a lot of people come in with dementia because they've had a Roux-en-Y gastric bypass and they're not absorbing nutrients. They're not absorbing vitamin D, they're not absorbing vitamin B, they're not absorbing folate, and that can cause dementia-like signs and cognitive impairment. So anyways, she had a fusion of her vertebrae. She had a lipoma removed on her sciatic nerve. She lives with her husband, as I mentioned. She doesn't drink alcohol or use illicit drugs or tobacco. She has no drug allergies, and all her labs were within normal limits. But she kept coming back to our clinic like every month, and she'd come back early looking for refills of her pain medicine. And since she was fairly new to us, after about the third month where she'd come back a week early, saying that she's run out of her morphine, we finally pulled the report that says what controlled substance the person's filled in the area. In our area, it's a tri-state because it's Ohio, Indiana, and Kentucky. And we found that she had been going to a doctor for pain medicine. Of course, she didn't tell us that before. And so we called the doctor, and it turns out it was a pain clinic, and she was fired from the pain clinic. And so we asked why, and she was fired from the pain clinic because she failed the urine tox screen. In other words, she was given OxyContin, and she did the urine tox screen, and none of it showed up in her urine. So they fired her. But when we looked closer at this case, we figured out that we'd given her morphine sulfate extended release. It turns out that because of her gastric bypass, she wasn't absorbing the medications for her pain like she was supposed to. And so she would up the dose trying to get relief. The morphine sulfate immediate release would absorb just fine. So it turns out that the way these drugs are designed, morphine sulfate extended release, or OxyContin, which is extended release, it's designed to dissolve in a pH of your intestine, which is a little higher. But the dissolving starts in the pH of your stomach, which is like 1.4. It's super, super strong acid. But her stomach, because it had been reduced, didn't have enough stomach acid to start the pill dissolving. So actually, this lady was fired from the pain clinic, not because she was abusing her medicines or selling them, but because she couldn't absorb them. So when it comes to older adults, you have to think out of the box when you're trying to solve a mystery. And this case was a clear case of nobody figured out what was wrong until finally, actually, was our pharmacy resident and myself who figured that one out. So this is just to explain what kind of altered drug absorption happens when it comes to gastric bypasses. There's a lot of things that change. And I just want to share with you that the future of pharmacy is really very bright. I know that it may seem with a lot of schools and a lot of graduates that there aren't enough jobs, but I would just tell you that I see a totally different thing based on the people that I know. And think about it, the people I know are aging and retiring, and someone's got to take our place. I have friends who are PharmDs. They work in industry, medical science liaison. I don't know if you've heard of that job. That's where you're a liaison between the doctors and the company. You're not selling pharmaceutical products, but you're helping them with clinical trials, and you're finding out about their use of their drugs and bringing that back to the home office. You can work in a health system. You can work in the government. You can work in national organizations like ASCP. You know, they have fellowships for students. You can be a senior care pharmacist. You can work as a legal professional. I actually do a lot of expert witness cases, and this year alone, we've beat Walgreens and Walmart because they do mistakes, and then their counsel doesn't know how to defend them. So there's a lot of good work there. There's work in technology, and you can be an educator. And by the way, you can be an educator in nursing school, therapist school, dentistry school, medical school, all of those things. You don't have to be just a pharmacy school educator. So I'm going to leave you with the famous saying of William Osler: "The desire to take medicine is perhaps the greatest feature which distinguishes man from animals." And the truth is that there will always be work for us, because I don't think taking medicines is ever going to go away. And on the horizon are biologicals. So there's always something new. Thanks a lot, you guys. Let me stop sharing and open up to the group. Now that you're in a coma. Sorry.
Thank you, Dr. D. I'm going to share a link with you guys if you wanted to sign up for everybody. As we mentioned in the beginning, I'm just going to leave it in the chat for everybody. But we would now like to open it up for any questions. So if you have a question, feel free to speak up and say your name and your question for Dr. D or any one of us. And if you don't want to say your name or remain anonymous, you can do that in the chat as well, and we'll try to answer your questions that way.
So I'll just share with you with this COVID thing going on. I'm taking 3 extra pharmacy students on rotation starting in May. And the reason is the clinics are all closed down. And my rotation is scholarship and education and research. So that can kind of be done virtually. It's not going to be easy, but we're going to do it. But it's kind of like I would like to just extend an offer to any of you guys. If you ever want to collaborate on scholarship or creating educational pieces or research, I'm happy to do that, because that's kind of what I do.
I have a question.
Yeah.
So you said that for like elderly people and when they have a lot of medications, it's a polypharmacist expertise to like look at them and conciliate all their medications. Where would someone go to like do that, since they probably won't be able to go to the regular pharmacy because they don't have that specific expertise?
Oh, that's an excellent question. So, you know, I do a lot of talks to a lot of groups, and first question is always, how do we get an appointment with you? And I have to say, well, I don't have too many appointments because the healthcare system doesn't pay for that, right? You've probably figured that out, right? The reason the pharmacist doesn't stop what they're doing and go through the medicines with you is because they don't get reimbursed for it. You've probably heard about the Medicare D medication management program. It reimburses the pharmacy $1 a minute, so that's $60 an hour. But to do that consult, you have to spend about half an hour before that hour and another half an hour after writing it up and gathering the data. So it's just not a strong enough reimbursement to make it happen. But I've seen a couple of ways that pharmacists get paid to do this, even now. For one way is through what's called value-based purchasing. Hospitals have, under the Affordable Care Act, they get paid for improving their quality measures, right? So preventing people to come back to the hospital after they're discharged, or preventing delirium or other indicators of bad care. And if you look at the top 10 things that, there's this program that the American Medical Association puts out of the top 10 things that you should talk to your doctor about. 7 of them involve medications. So when I was a consultant pharmacist, I would get the quality measures of the nursing home. They have a report every month, and I would use that as my roadmap. So if they would get in trouble for too many falls, then my job was to go in and find out what medicines were causing people to fall. Or if they had too much urinary incontinence, then my job was to find out, well, what are the medicines doing to cause that? And so that's one way that pharmacists are starting to get reimbursement for that kind of work, is they're joining medical teams and cleaning up the medicines, basically. The other way it's happening, and when I retire and come back to LA, I'm going to just hang a shingle and do it myself. I mean, there's like concierge practices. And I have friends who do really good doing that. You know, just like almost like, okay, yeah, you pay me $3,000 a year to have one phone call a month and a face-to-face. People will do it. People will do it for their, like, okay, maybe the older person won't do it, but their adult child will do it. Because like my mom's 93 and she lives in Monterey Park, right? And I don't know what she's doing 90% of the time. I would pay somebody to go over her house and check it out. You know, I would gladly do that. Oh, you guys are going to laugh about this. Speaking of my mother, when this COVID thing happened, I told her, you're not allowed to go to the Chinese grocery store. No more. And of course, the first thing she does was go to the Chinese grocery store. So then I call her the next week and I go, oh, what are you doing? She said, oh, I went to yoga. I'm like, you what? You went to yoga? Where? At the senior center, the Chinese senior center. And I'm like, Mom, so this is one of the problems with older adults is like when you're interviewing them, you have to interview all of their family to find out what's really going on. So in some ways it's highly specialized, and I really think that that there's a good future in doing like specialty concierge business with medication management. Look, I teach at med school. I can tell you, and I'm going to say this, my kids are physicians, my husband's a physician. They don't know how to manage medicines. They really don't. And I think pharmacists are much better qualified. It's just that we haven't kind of stepped up and advocated for ourselves. But I think part of that's confidence. So you got to have confidence that we're really the only ones who can do that MTM stuff, actually. Yeah.
We had one more question in the chat from Ryan. He says, how does COVID-19 affect the work of geriatric pharmacists? And will more frontline work be required? Are there any implementations to protect senior care homes from contracting the virus?
Oh, that's a great question. So you're probably aware that places where older adults live, they're just shutting them down. Like they're not even letting family in to visit. So the geriatric pharmacists can't go in the facility, can't do their normal job. But thanks to EHRs, a lot of that can be remote now. But the other problem is that the the pharmacies, so in geriatric pharmacy, you've got the consultant pharmacist, you have the operations pharmacist, that is the one who manages how do you get the drugs delivered and how do you get the emergency kits there and everything. And then you've got the kind of, you have like a clinical inpatient pharmacist, you might say, that fills all the orders. Well, when the COVID infection hit, at least here at our nursing homes, our pharmacist made a special effort to revise the medication dosing so that the patients wouldn't have to get as many doses a day, because they wanted to minimize the exposure to the caregivers. Like if somebody was taking, pain medicine 3 or 4 times a day, they switched them over to 1 or 2 time a day drugs. One of the problems with that is, again, older people don't swallow too good and you can't crush those. But that was one of the jobs of the pharmacy, was to figure out how to streamline and minimize the polypharmacy so that you didn't have to interact with the patient as much and risk, because the spread of the virus came from the caregivers. It all came from the staff, basically. And the outcome, a lot of deaths. It's really kind of sad. And then what, I don't know, I think, are you guys participating in that helping the seniors program at USC? Weren't they doing something where they're calling people who are kind of shut in, sort of? And
Yes, so there is a program that one of our faculty advisors, Dr. Gervich, shared with us, where students from any healthcare discipline can volunteer to talk on the phone with seniors, and not necessarily anything related to medications or anything, but just checking in on them, seeing if there's anything that they need or anything that they need to talk about. So it's a really great program, and if any of you guys are interested, I can see if maybe they would take on any undergraduate students, but just feel free to let me know.
It's wonderful. And with regard to COVID, there were some people who refused to go, some of the staff who refused to go in the nursing home. And actually, I know a couple of senior care pharmacists who volunteered. They just gowned up and they volunteered. So I thought that was really sweet. Oh, so Kenneth has a question. Okay, so Kenneth is asking, every time I go to a meeting, hear about different paths and get interested in learning how about that path. Oh, when you joined USC, how did you decide to pursue geriatric pharmacy over the other paths? Well, so what happened? Are you talking to the club, right?
Yeah, I was more directed to them.
You guys go ahead. Karolina? Or Kristen, or?
Karolina, you're muted.
Sorry. We also have one of our vice president of ASCP, Kristen, on the line. I'm not sure if she would like to share her experience, but she is really passionate, and she's one of the students that is actually doing a dual degree and is doing her master's in the specific field. Kristen, would you mind sharing a few words?
Yeah, thank you for the question. That's a really great question. And thank you, Dr. D, for the talk. She hit a lot of really great points that really drew me to geriatric pharmacy. Like she said earlier, a lot of people who get interested in it is because they have grandparents or they have experience with older adults in their family, which I have a lot of older adults in my family that are taking a number of medications and that are basically going through a lot of chronic disease states. So it's really hard to see them deteriorate. So I think it's a really great field to go into, and I really love that it's interdisciplinary. You get to interact with the physicians, with specialties. So it's really a team-based practice, I guess you could say. And right now I'm at the VA in West LA, which is where Dr. D did her residency. So I've had a really great experience there, even though I don't get to see patients face to face. It's really cool to see that someone who's 94 is like doing really great. And then someone that's maybe 75 is not doing so great. So you can't just judge a patient based off of their age. You really have to take into consideration their whole story and really get to know their background and treat them as a whole person. So, yep.
And then to add on to Kristen's answer, I guess I understand where you're coming from with all the different paths presented to you and not knowing really where to, how to approach it. So in my experience, currently Karolina and I, we both work in inpatient pharmacy, so acute care. And for me, I'm in my second year, so I'm still being exposed to different settings. But what interested me in geriatric pharmacy is that regardless of what I decide to pursue, whether that's acute care or ambulatory care, just knowledge that I acquire through learning more about geriatric pharmacy can be applied to all of these different settings. So that's kind of what drew me to the field, even if I'm not set on necessarily pursuing geriatric pharmacy specifically or consultant pharmacy specifically. It just leaves a lot of options on the table for me.
Yeah, I mean, any area you work in, right? If it's oncology, high percentage of your patients are going to be older. Okay, anything except pediatrics, but even in pediatrics, you got to deal with the grandparents, right? So that's part of it. The other area that's kind of a growing area, you know, we have our like our kind of grand rounds every week, and we had an interesting case of here in Louisville. There's a very large Vietnamese immigrant community, and it's an old one. People came here like right after the war. And so now there's a lot of aging people, and actually the grandfather of one of my students, who now is a pharmacist, he ended up on our hospital service, and it was kind of scary. What happened was he had a pretty severe diagnosis, and he misunderstood the translation, and he thought they were saying he was dying. And so he pretended he had pain, and he got a bunch of pain medicine, and he tried to kill himself. And when we got him on the hospital service, you know, and we saved him and everything, and my friend was there, who was my student, and I said, what happened? And then he explained that his grandfather misunderstood the healthcare system, right? Because the healthcare system's not very easy for anybody, especially an old person. And then if there's a language barrier, it's even worse. And so once he understood that wasn't the case, then we were able to get him the support and help that he needed. But the point is that we have also an aging cohort in the United States that the American healthcare system is clueless about. Like, we also have a very large Bosnian population here, and I've seen the exact same thing. I mean, not that kind of misunderstanding, but so I think there's a lot of area where, as young people, you can grow and do things that the older generation didn't do, and it's causing gaps in care. I know that's a little tangential, but I just thought, you know, what could be good for your generation? You guys can change things, and think outside the box. You know Steve Chen at your school, Steve Chen? So he was like that. He always thought outside the box all the time. See, and then those are the people who end up innovating. So, well, I hope I get to see you guys in person. I'm over there all the time. When the airplanes are flying, I'm there every other month. But nowadays, I don't know.
Yeah, and same for us. We would really like to encourage you as students. I came from UCI, and a bunch of my other classmates did as well, and we definitely know what it feels like to be in your position and would love to help in any way that we can. If you wanted to reach out to us separately or join us in any events, we would really invite you. We would love to have you and share our knowledge and share our love for geriatric pharmacy with you. So please feel free to contact Kenneth or Kristen, and they'll be happy to share our information with you, as well as the PowerPoint. And just as a recap, we did provide the link for you to sign up if you would like to receive more information from us. It's totally fine if you are bombarded with emails and don't want to, but this is just a quicker way to get it to you directly. And with that, I think we'll pass it to Kenneth to finish off the meeting.
Okay, thank you so much, Dr. D, Valerie, Kristen, Karolina, and Marcella for presenting to us about geriatric pharmacy and answering all of our questions. Yeah, so like they said, please check out their link, and we'll have a recording of the Zoom meeting as well as the PowerPoint shared in our weekly emails. If that's it, thank you so much. I'm gonna share the clue for the treasure hunt we have. Yes. Let's see. Okay, PPS treasure hunt. How do I do this? Present. Okay, so the clue for this week: where can you find Din in a pill bottle costume? Don't forget to fill out the Google form to submit your answers by every Friday at 11:59 p.m. Okay. Thank you so much, everyone, for coming to our general meeting. With that, I'll conclude it here. Stop sharing. Okay. Thank you, everyone.